Paul, when I do the slide we worked on last night,
Yes.
my thought is this is one where I think it'd be good for us to do the back and forth.
Yes,
Does that make sense to you?
it does.
Hi, this is the ND Mic team. Is the CMS auditorium on the line?
And that one's at the end.
Yes, we are.
That's
Can
number
you hear me,
35.
Ashley?
Yeah.
How about I do one?
Talking to the mics.
Christine, Fred.
So Dennis.
Hi, can you hear me now?
Dennis, Paul.
Fred, this is Jennifer. I can hear you now, yes.
Excellent. Let me just check in to see if we have Miss Jean Moody Williams on the line.
Yes, she is on the line.
Excellent. Miss Jean, would you mind just saying a few things for us, please?
Hello, Fred. Thanks for all your work in getting all this together. It's great.
Excellent, Miss Jean. We can hear you very clearly. JP, would you mind just saying a word or two?
Sure. Can you hear me, Fred?
Yes, thank you very much. Dr. McGann
Welcome, everyone, to today's session.
and Mr. Wagner.
Good afternoon. And Gene, I'm delighted to hear you're on the line. We've been scrambling around trying to get you the right number, and you've been diligent right on top of it, and we're very grateful.
Commander, could we hear you from that microphone?
Can you hear me from this microphone?
Check, ma'am. Thank you very
Got it.
much. Excellent. Charles, thank you for everything. All right. As we begin this session, we'll start out with the introduction of the actual session, and then we'll move quickly into the presentation on the quality payment program. Ms. Jean Moody Williams is going to begin for the ND Mic team's knowledge. Then she's going to transition it over to our panel here in the room. We will then stop at approximately 4:40 to interact with individuals on the line. And then we will have Dr. Robert Fleming introduce Dr. Conway at 4:55.
Lieutenant Butler, this is Jennifer. If I could interrupt for 1 moment, I want to confirm a logistics element. Lieutenant Butler, can you hear me, sir?
Yes, ma'am. Go ahead.
Okay, thank you. I just wanted to confirm that there is a video on slide 36 of the deck that CMS will be proceeding with, and I want to confirm that on slide 36 that you must put yourselves on mute in the room at CMS, otherwise we will experience feedback for those participating online.
Oh, we're not planning to show the video on that slide. We want the slide to be available for participants so that they can see the video, but we will not be playing the video during this session.
Understood. Thank you for confirming that. We will not play the video when we hit slide 36. Thank you.
Excellent. Thank you for asking.
And Mr. Charles, can you show us what the CMS YouTube is going to be showing at this time as a test before we go live? Or are we ready to go live, sir? Okay.
We are live.
Excellent. Good afternoon, everyone.
It is live right now. We are seeing the video live at the moment.
All right, if we could have the ND Mic team go on mute.
We're still in pre-conference. This is Michelle, the operator. Should we begin the conference now? We're still in pre-conference.
Yes, absolutely, please.
Okay, please stand by.
The conference is now started. This conference is now being recorded.
Good afternoon, everyone, and welcome to Day 2, Part 2 of the TCPI Virtual Learning Session. We welcome all of the clinicians that have joined us today. Thank you very much to the Practice Transformation Networks and the Support and Alignment Networks that have made that possible and spread that information. We're also joined here by a number of the TCPI team members, project officers, contracting officer representatives, and a number of leaders from across CMS. Thank you all very much for your time. If we could go to the next slide. All right. This slide, we just wanted to make sure that we encourage you all to, as much as possible, listen in the room together. If we could go to the next slide. If you've dialed into a phone line, please make sure that you mute your computer speakers to prevent any audio feedback. And if you're not speaking, please mute your phone. If you're watching a recording of the meeting, there is a link there that's available. And if you have any questions, please feel free to reach out to us at the ND Mic at mail.healthcarecommunities.org address that you see below. On the next slide, We're currently on session 16, the Quality Payment Program. And what we would like to do is transition directly to our leadership team. We have on the line with us Ms. Jean Moody Williams, and she's going to kick us off for this session. Ms. Jean?
Thanks, Fred, and hello to everyone. I hope that you've been having a wonderful meeting, generating great ideas for success, and that there's quite a bit of learning going on, I'm sure. I had the opportunity to meet with many of you a few months ago about transforming clinical practice in general, and we talked at that time about the implementation of the Quality Payment Program. In fact, even prior to that, you all may recall that I came to you from the very beginning to test what we should even call this program. And your feedback and input was provided to our administrator and to our senior leadership team as we came up with the name. And so you, in fact, are much invested in the program from the very start. And so we've made a lot of progress since the last time that we talked. As most of you know, we have put out the proposed rule, and my colleagues will be talking about that over the course of the next hour. And as I mentioned at our last meeting, the outreach efforts and the approach to standing up this program has just been very user-centric, I would say patient-centered and physician-driven. So we have done quite a bit of outreach, including with you, and taken an unprecedented effort to draft a proposed rule that was based directly on input from those on the front line of care delivery. And then after the rule, proposed rule was published, we didn't just stop there and say, okay, now we'll wait for comments to come in and we'll read them and react to them. We continued the efforts so that we could listen and really know how to conduct a rule, draft a rule that was going to be meaningful and reduce unnecessary. In fact, we had over 200 sessions throughout the country. We met with 64,000 attendees with webinars, face-to-face meetings, traveling. We had over 4,000 formal comments come in from a wide range of stakeholders representing a very diverse group, really, I would say. We had engagements from consumers, from physicians, other clinicians, all who were, I would say, cautiously optimistic that we could really make a difference in how we set this program up. We've learned quite a bit in the process, and we continue to engage directly with the front lines. And I would say some things that we've learned through all of that discussion and questions and answers and going out into the fields and sitting in clinicians' office, but some things began to come together from the written comments as well that we received, and you could probably imagine what they were. Of course, it needs to be a program that is focused on the patient in everything that we think of, that the patients not only have input into the decision making and to the policy development, that the policies that we develop really work to make sure that clinicians have more time to spend with their patients, that it really supports the practice of medicine that they want to be able to provide. We, of course, heard that there's a desire to simplify the program and reduce burden. Sometimes in an effort to create flexibilities, it creates complexities as well. And so then what starts off as a simple way to approach something quickly can very quickly become a lot more complicated. And so trying to find the right balance of having those flexibilities and choices of how clinicians interact with the program, but still having it in a way that makes sense and that's simple to explain. The other thing, of course, we've heard is looking to see how we could advance medical homes and create pathways for more physicians and clinicians to be able to participate in the models that were proposed and that you'll hear about in just a moment. And then fourth, I would say we've heard quite loudly that we need to have special considerations for solo and small independent practices who may not have the resources that some of the larger health systems do for the administrative requirements. And of course, I know that many of you are working with these very clinicians that I'm speaking of, and who are very interested in transforming their practices, but that it may be a little slower glide path for them. And I would say, lastly, the program is scheduled to start, of course, on January 1st of 2017, and there have been many requests to really look and to see what flexibilities we have in the law that would allow the community time to learn and prepare for the changes. So we're considering all of those as we march toward a final rule. So as we spend some time today over the next hour, we really want to, again, highlight some things in the rule that we want to refresh. We want to talk about the importance of your role in helping clinicians be successful in these efforts. And we say that with all confidence that we know that you will be able to do that, and that there really is great expectation and anticipation about the work that you're doing and some of the tools that you've already created. I think I've had several highlights this week. It's been a good week as I've been out in the field, and I'm sorry I'm not on the video and YouTube because I'm actually out in the field right now. And so I know that Dennis and JP and Paul and others will take up the presentation from here. But one of the highlights that I had, I got an email earlier in the week from an association asking about this clinical practice initiative and how their members could get involved, because they're hearing such great things about there's this help out there and there's these networks that's really helping clinicians move along, and they wanted their members to be able to take advantage of some of this. And so, I let them know that PPNs is still recruiting and that there is help available, but I can say that the work that you're doing is already spreading, and you're already getting a great reputation for being problem solvers and go-to people. So I thank you for that, and thank you for all you will be doing in advance. And with that, I'm going to turn it back over and know that you will have a great presentation for the remainder of this time.
Very good. Thank you, Jean. And good afternoon, everyone. This is Dennis Wagner. I'm here at CMS. I'm the director of the Quality Improvement and Innovation Group. And we're going to have a very content-rich and action-packed session here with a lot of information for you. And it comes on the heels, really, of 2 days of just fantastic interaction, dialogue, very energizing, also very content-rich, that the CMS Transforming Clinical Practice Initiative team has had with the 29 practice transformation networks and the 10 support and alignment networks, and many of the QIOs that also are integrally involved in the Transforming Clinical Practice Initiative. To the clinicians that are joining us for this special session on the merit-based incentive payment system and the quality payment program, I want to say that the PTNs and the SANs and the QIOs that you're connected to have a direct pipeline into CMS on all of this content and all of this work. And the moment decisions are made, the moment content modules become available, the moment challenging questions get answered, that information will be instantly available to the PTNs, to the SANs, and the QIOs that are part of this. So you're teamed with the right folks, and we're delighted that you're part of this call that we're having this afternoon. As you see on the slide in front of you, we're going to cover the quality payment program, the merit-based incentive payment system, and then incentives for participation in advanced alternative payment models. You're going to hear directly from national experts on this. we're going to try to work to tie it all together at the end, and we're going to have an opportunity for some questions and answers. And maybe to talk a little bit more about those questions and answers, I want to turn to my colleague and close working partner here at CMS, Dr. Paul McGann. He's been with CMS for 15 years, is deeply steeped in the workings of this agency, and this follows on more than 20 years in practice. Prior to that, he's a leading national geriatrician and is really a national treasure and an asset. So Dr. McGann, you want to talk a little bit about some of this question and answer we're going to do?
Thanks, Dennis. Thanks for the kind words, too. I have to tell the audience that's looking, not only live, but I hear this is going to be on YouTube later, so I'll have to show my children. We're all very excited to be here, and this is really, I think, a historic moment, especially in TCPI. But before I go, I think the viewers, Dennis, that are going to be watching us later especially need to know who the other people on the stage are. So maybe I'll ask JP and Dr. Fleming if they could just introduce themselves.
Yeah, hi, thank you, Paul. I'm JP Sharp, and I'm the team lead for the Quality Payment Program on the APM policy side of things, and I'll be walking through a lot of the content that you hear today.
I'll keep it brief. I'm the director for the Transforming Clinical Practice Initiative, Dr. Rob Fleming, as Dr. McGann has already introduced.
Great.
Thank you.
So this is going to be a very exciting, action-packed presentation. You see two questions on your screen right now if you're watching the screens. And I'm going to suggest to you that you listen to this presentation in a way that's completely different than you ever listened to a presentation like this before. And what I mean by that is you're going to hear about the latest payment rule that CMS published in the Federal Register as a notice of proposed rulemaking. It's complicated, and there are a lot of details, and you're going to hear a virtuoso performance of someone who's mastered this over the next 20, 25 minutes or so. And your instincts, I know my instincts as a clinician, are going to be to take notes and try to learn everything the first time around and memorize all the rules and figure out what goes up and what goes down and how you're going to make all these decisions. And I want to reassure you that you don't have to do that today, because that's stressful, and CMS has published hundreds of payment rules, and you don't have to do that anymore. And the reason you don't have to do that anymore is because you're with TCPI. And TCPI is our 4-year commitment to be with you to help you understand this in the months and years to come. So you don't have to worry, and you don't have to be anxious. And instead of doing what we usually do, I'm going to ask you to do something different. As you listen to JP talk about this program, ask yourself 2 simple questions. Question number 1. What are the benefits to participating in TCPI, a 4-year commitment by CMS to help you transform your practice? And probably an even more important question, question number 2, the strategic question for participating clinicians. Where do I want my practice to be 5 years from today? Because JP's presentation, if you run on those questions, JP has answers for you. And we're going to return to these questions at the end of this technical presentation and ask for your answers to these, because this could really transform the way you practice medicine and bring joy back into your life. JP?
Well, thank you, Paul. So I am going to move through a lot of material, probably faster than we'll all be comfortable with. But as Paul was saying, it's important to take this in the light of understanding the overall framework that we have for the quality payment program, so that you can understand when we have the final rule what all these pieces mean and how they fit together. So we're not going to focus on the particular numbers here and there on each slide, but we're going to go through what is the meaning of this when you're in one track or the other track, and so and how do they work together, so that everything you hear from now on hopefully will kind of fit into this framework that we go over. So here on this first slide, you'll see the top line items, those first 3 check marks. So one, the big impetus for this is that the sustainable growth rate will no longer be in place, so there are no looming cuts to physician payment rates. So along with that, we have a new program that streamlines by sunsetting the PQRS, value modifier and meaningful use programs, and merging them into one consistent streamlined program called the Merit-Based Incentive Payment System, or MIPS. And then the other track that we'll talk about are specific incentives for participation in advanced alternative payment models. And we'll get into this because there are a lot of new terms, and so that's kind of part of the landscape that we'll be laying out here. So I'm going to start jumping.
JP, just before you jump, I want to point out a really important distinction with this payment rule and others before it. You have a choice. There are two branches. There's MIPS this way and alternative payment models this way. JP's going to explain what that means, but you need to decide which pathway is best for you and your practice in 2016, 2017, and beyond. And JP's now going to give you the information you need to make that leadership choice for your practice. JP?
Yeah, that's absolutely correct. So thank you. So this is usually before we had the close of the comment period. We had this slide here to encourage everybody to submit comments, and we received nearly 4,000 of them. And so those are things that we are actively looking at and thinking about right now before we finalize the rule. So diving into the content, we'll first talk about MIPS and what that means. And then after that, we'll talk about those advanced APMs and the incentives you get for participating in them. So for starters, MIPS, as we said, is this new program. It streamlines PQRS, value modifier, meaningful use. So as independent programs, those last payment adjustments will be in 2018. So starting in 2019, payment adjustments will be through MIPS. And you'll see that there's corollaries for these performance categories. So you see these icons for quality, resource use, clinical practice improvement activities, and advancing care information. And you'll see that quality sounds familiar for PQRS, resource use sounds like value modifier. I'll skip over to advancing care information is the modified new version of the former meaningful use program. Then the new one that's interesting is clinical practice improvement activities. And we'll talk a little bit about each of these categories coming up, but that's the addition to the package that comprises MIPS. So participation. So to whom does MIPS apply? And it changes a little bit. There's a ramp-up period. So the first couple years, you'll see on the left side of the slide here, that there's a specific group of physicians, PAs, NPs, CNS, CRNA. So that discrete group are the people who, in those first 2 years of the program, will be receiving adjustments under MIPS. However, in the third year and later, that can expand to include much broader range of Medicare enrolled clinicians. When we get to the advanced APM incentives, there's no such distinction. Actually, the incentives are available to that group on the right, starting right at the beginning. So there's less of a ramp up for everybody if you're in these advanced APMs. And note that the MIPS payment adjustments apply to physician payments in Part B of Medicare. So that's really what this focuses on. So it's not looking at facility payments, hospitals, what have you. So this is an important slide. So there are exclusions from MIPS. So even if you were in those groups in those previous slides, there are a few categories where you're just categorically not going to be subject to these MIPS adjustments. So first is if it's your first year of Medicare participation. Second is a low volume threshold. And so, as I said, we won't focus on these numbers here, but in general, we want smaller practices who see fewer people to not be subject to these adjustments, especially in the early years, so that if you don't have a lot of Medicare business, you don't have to worry about the MIPS adjustments. And then the last one is this connection between MIPS and the advanced APMs. So these certain participants, and we'll get to all these definitions later, but if you're participating in advanced alternative payment models, you can be excluded from MIPS and instead receive different incentives for being in that part of the quality payment program. And this is a little conceptual diagram. It's not to scale, but just to set expectations that right off the bat in 2017, when we start our first performance assessments, most people will be in MIPS. fewer people will be in advanced APMs, and that's just because there are fewer opportunities at this particular moment in time. However, we want to have more and more opportunities each year to join advanced alternative payment models, and we think that TCPI is the perfect channel to help people become prepared to move from the left side of this screen over to the right side, where we meet these larger departmental delivery system reform goals of having more and more people in APMs. So back to looking at MIPS in particular, there are a couple ways to report and be scored: individual and group, which will be defined by TIN. So I'll just keep moving. That should be pretty simple there. So this is a little more detail on each of those 4 performance categories. And again, I won't talk through each of these points, but you'll see that there are particular scoring methodologies that have been proposed for each of these. Different measures will apply to each of these performance categories. And then each of them, according to the MACRA statute, have particular weights. So you see at first quality is weighted most heavily, and the resource use or cost is weighted less than the others, though actually that cost one will increase over time in its weight and the quality one will decrease accordingly. So you'll see those shift a little bit over time.
And JP, I want to try to help the audience. Remember that first question I had? Are there any particular advantages for the quality payment program, MIPS or APMs, for those clinicians that are participating in TCPI? And I think the answer, one of the answers, there are many answers to that, but one of the answers to that question is on this slide, isn't it, for this particular category?
Yeah, absolutely. This clinical practice improvement activities, because it's new, one, but 2, these are directly related to the types of things that we want to move people's practices into this next stage of their life cycle and be ready for APMs and more patient-centered care. And so that's what you'll see in that CPIA category, are actual processes and activities that we know have great impacts on patients and the development of clinical practice.
And clinicians that sign up for TCPI kind of get a head start on that CPII category.
Yeah, absolutely. So, and this is another link between the APM side and MIPS. So just by being in TCPI or any other APM, which is, we'll get to what that means under the law in a little bit, but just by the participation, you start off with a minimum of half that score. So you start off with 50% of the CPIA score. In fact, if you're in a patient-centered medical home or a medical home model, which we'll talk about later, you get 100% of the CPIA score. So those are valuable activities to be part of.
Thanks, JP.
Yeah. This is a quick graphic just on the overall timeline as proposed. So have performance period 2 years prior to the payment year. So just keep that in mind. We'll pull all the time frame together at the end of all of this. So then we have payment adjustments. So we looked at those particular performance categories. How do they tie together and result in actual changes to the way people get paid? So you take each of those weights we looked at, each of the scores in those performance categories, and they become one composite performance score, or CPS. And that can range from 0 to 100. And depending on where that lands in relation to a performance threshold, you can have positive or negative adjustments. And we'll look at this a little bit more here. So the program, it's important to remember, is budget neutral. So overall, the estimated dollars on the negative adjustment side will equal those on the positive adjustment side. And to do so, there's the possibility of a multiplier on the positive side. So it can go up to a multiple of 3. So you can have increasingly high positive adjustments if you're a very high performer under MIPS. For the first 6 years, you'll see the second check mark here. There's this exceptional performance bonus. So that can be even 10% more on top of the additional positive bonuses for those who are very successful in MIPS. So again, this underscores the importance of having technical assistance like TCPI to make sure you're kind of at the top end of this because the rewards are pretty great here in the MIPS
And
program.
many of the targets we saw in your proposals in TCPI are in that exceptional range. So if you hit your targets, there's actually rewards for hitting those targets that you created.
And this is just the graphical representation over time of what the maximum adjustments are. So they'll start off with a positive or -4, and they'll move up to 9%, including, of course, those scaling factors on the positive side, and that exceptional performance bonus can be in addition to these.
So JP, just like clinical practice, the clinicians out there are all under extreme time pressure to see patients faster and faster, and it turns out so are we. And we're getting signals here that we've got to really abridge the alternative payment model part. We can always come back because we got a 4-year commitment with these people. So I just asked if you could race through the next part, then we'll keep our program on time.
Absolutely, we will do that. So we'll frame it here first. So there are incentives for participation in certain types of APMs. And we'll start off with the big definition of APM, and then we'll get to those particular APMs through which you can get incentives. And that's the main part, is understand where you can participate and what incentives you get for being there. So this is the basic definition. So there are a lot of APMs, very broad swaths. So everything that the Innovation Center does, the shared savings program, other statutory demos. When you start with that definition, certain APMs that have relatively rigorous requirements in them will be called advanced APMs. And those require its participants to use certified EHR technology, first check mark there. They base payment on quality measures that are comparable to those in MIPS. And then third check mark is the most complicated one, but it's an either or. So either the APM requires its participating entities to bear more than nominal financial risk, or it's a medical home model that's actually been expanded under the Innovation Center Authority. And we'll talk about that a little bit more later. There's also something to look at, and I recommend going back to this a little bit more because we can't get through all this detail now, but medical home models have an important place, and this is a specific type of APM. So within that broad category of APM, medical home models are those that focus on primary care and empanelment of patients. And for those, they have a little easier path to becoming advanced APMs. And they also, if you recall, would get you that 100% credit in that CPIA category under MIPS. So those are good places to look. So we have the details on each of those 3 criteria to become an advanced APM. So what makes an APM an advanced APM? And again, don't focus on the numbers here in particular, but this first one is really that in the design of the model, it's requiring a certain percentage of clinicians in an organization to use certified EHR technology. And that's really the basis of this requirement. The second one is these quality measures that are comparable to those in MIPS. And there are a lot of words here on this page also, but the main takeaway is that if the APM bases payment in some form on measures that are evidence-based, reliable, and valid. So look for evidence-based, reliable, and valid, and having some payment effect based on the performance on those measures. And that's how an APM could be an advanced APM. And then the last one is this complicated one, is what does it mean to bear more than nominal financial risk? And again, don't need to focus on the particular aspects of it, but what we're looking at here is really downside risk, and that can come in various forms. It can come from repaying shared losses in a shared savings type program. It can come in withholds of payments or reduction in payment rates. But either way, there must be some downside aspect to the model. And then the second part, just look for in the final rule is that particular amount to give you a sense of the magnitude of risk that you have to take on in order to be an advanced APM. And then we will always do all the technical work for you and come out with a list. So you don't have to line things up and figure out which APMs are advanced APMs. We will tell you every year which opportunities you have to be in advanced APMs. So this, it comes with the caveat that currently structured available models, and as proposed in the proposed rule, these are the opportunities starting right at the beginning of 2017 that would be advanced APMs.
And JP, for those who can't see the slide, there are 5 models that are pictured on this slide. One of them, CPC+, but there are others. So we've already figured it out for the first year, but as JP says, this is a dynamic model. It's going to change every year.
Yeah, we are going to be continuously looking for new opportunities, changing existing models to get them to advanced APMs. And so keep an eye on this list growing pretty quickly over the next couple of years. And then on the other side of this is, so once you get into an advanced APM, there's a little bit of a hurdle still that the law sets forth to get the incentives. So that's determining who is a qualifying APM participant. And what we'll do is really just assess the percentage of either your patients or your Medicare payments that are through that advanced APM. If you meet these thresholds, which we anticipate a lot of people will at the beginning, and those thresholds become increasingly difficult over time. But then if you become a qualifying APM participant, or QP, you're excluded from those MIPS adjustments, and you automatically receive this 5% lump sum bonus. So we'll calculate your payments for Part B professional services, take 5% of that, and send that to you in a lump sum form. In the interest of time, I will not go through those steps on how to get to the QP status. But this kind of lines up the stepwise approach to becoming a QP and receiving these incentives. So it's a nice graphical representation of, as proposed, we would have this performance period where we see, are you in an advanced APM? If so, do you meet those thresholds to become a QP? If you're a QP, we'll add up all your payments for Part B professional services, take 5% of that, send that to you in a lump sum payment in the payment year. And then that repeats every year, so they will overlap over time. And then this is where I will leave it off, but this is to give you a sense of scale and relationship between the different incentives across MIPS and these advanced APM payments. You'll see what we just went over is at the bottom, and those are limited in time. So it's really a boost to get people into these advanced APMs, where each in themselves have their own rewards and risks, but this is an additional bonus to get in there. And then you'll see overlaid with that are those MIPS adjustments we saw, and then finally the long-term difference. After these advanced APM bonuses end, they start getting, as a QP, you'd start getting a higher fee schedule rate. So it starts to diverge between QPs and non-QPs over time. So as we go forward, QPs will get a higher and higher base rate for the services that they provide.
Thank you so much, JP. That was absolutely masterful. I'm really in great admiration of your mastery of this. It's really good, and you explain it so clearly, so thank you.
Yeah,
Dennis?
thank you.
So this really is here for all of us at CMS, and I think for the clinician community nationally, the first step to a fresh start. The SGR is going away. The quality payment program is replacing it. And we will be implementing the law that's required, right? But we want to do that in a way that's helpful, that's consumer-centered, that's patient-centered. And the partnership that we have with the practice transformation networks, the support and alignment networks, the quality improvement organizations is a key step in that business of being open, flexible, and user-centric. We're connected to those of you who are deeply connected to clinicians around the country, and we want to be in partnership with you in that work. Now, Dr. McGann, you set up a question at the very beginning here for our audience, and it was all around this business of how does then the Transforming Clinical Practice Initiative help? How can it help clinicians with the quality payment program? And it turns out there are quite a number of answers to that, and we've heard a number here. We've got 4 on this slide, but it's not like there's 4 ways. It's more like there's 44 ways or 104 ways. Right. So we're very interested in hearing your answers to this, and we're going to come to that shortly. But I'll just begin by saying, as we did in the beginning, the work of TCPI is directly aligned with the merit-based incentive payment system and the quality payment program. And PTNs, SANs, QIOs are directly connected to CMS and are a direct pipeline into the very latest of information that they will make available to their participating clinicians. What else, Dr. McGann?
And bullet number 2 on slide 35 is what JP pointed out as soon as we got to it. Clinical practice improvement activities. I'm a quality improvement physician at CMS. I've never in my life seen benefit for people engaged in clinical practice improvement. And here it is in a payment rule, Dennis.
Yeah.
Like, this is amazing. And JP explained to you, you get credit for being in TCPI. You get even more credit for certain medical homes. And it's just, it's a new day in town for physicians that are dedicated to quality.
Well, and this third one, so at base, TCPI's central goals, the reason that CMS fielded the Transforming Clinical Practice Initiative was to help improve health outcomes, help clinicians improve health outcomes, help clinicians to generate lower costs that benefit the nation and benefit the patients that they serve, and then to help 140,000 clinicians graduate into advanced alternative payment models where the additional bonuses become available. So that certainly is one of the key ways I think that TCPI can help.
And the last one here, it's just back to what we said right at the very beginning. Normally, these payment rules cause lots of anxiety, and probably it's causing a little anxiety still. But I'm asking you to relax, and the reason I'm asking you to relax is we are with you. This team you see here and all of the people working with us, the PTNs, the SANs, the Quinn QIO program, the new technical assistance contractors, the TCPI clinicians, we're all in this together with considerable resources that we have thanks to Dr. Conway, who you're going to hear from in a minute. And we're with you for the next 4 years. So this is different than anything that's happened before, and we're all going to get through this together.
Now, we had a session earlier today with PTNs and SANs where we had an opportunity for requests and offers among our community of practice. And one of the requests that we heard from multiple PTNs actually was, give us short, concise materials and information about the merit-based incentive payment system. Tell us how this works. And you see here a slide, and it's actually got a video. I could click on that button and play a video, but we're doing YouTube, and we don't want to do another YouTube on top of the YouTube we're already doing. So we're going to make this available to you. So this is a short video, but it's the 4 to 5 minute story on the quality payment program. And it's available to you, and it's part of making things as simple as possible.
And
as
you know what
were saying,
it also
Dr.
does,
McGann.
Dennis? It makes it fun.
Yeah.
I know it's hard. I know there's a lot of money at stake, but practice and practice transformation should be fun. And the reason we're showing you that is it's fun. So watch it for that reason alone.
Excellent. And JP, you want to say a little more?
Yeah, so this is a very important link. So if you want to know more, if the video and what I just said isn't quite enough for you to feel comfortable with it, this link will have all of our public materials that we've created so far on there. And that goes all the way from the actual rule itself all to fact sheets that are very specific, such as on advancing care information under MIPS, or how small and rural practices should think about the quality payment program.
Excellent. Now, this wouldn't be a federal presentation without this slide, right? So maybe you want to say a few words there too,
Yeah,
JP.
this is in all of our slides, but just to give the caveat that these are our public statements here, that we are in the rulemaking phase between receiving the comments and writing the final rules. So just keep that in mind.
All right.
And thanks so much for being willing to do this, JP. It's daunting to present material with this level of complexity. I think Gene mentioned complexity at the beginning. But I hope you feel how different this is. We've got the complexity. We've got to obey the law. We're putting out a proposed rule. But we're here with you, right? And we're showing it to you. We're interacting with you. And in fact, we're going to go to the phone now, Lieutenant Butler. And I really want to ask the audience, I know it's almost an unbearable temptation to ask 478 questions about what JP just said, but please first try to offer a few answers to the 2 questions we started with. What do you, the audience, clinicians, see the benefits to participating in TCPI, and where do you want your practice to be 5 years from now? Lieutenant Butler, can you help us with the audio connection here?
Absolutely, Dr. McGann. Is the operator with us? If we could go...
Yes, I'm here.
Thank you so much, ma'am. If you could give the instructions for individuals to put themselves in the queue by pressing 7#, we'd greatly appreciate it. And if you could give us our first responder, we would like to possibly hear from our national faculty members.
Will do. And as Fred had pointed out, if you have called in, would like to queue up for verbal questions or comments, please press 7 and the pound sign on your phone now.
And while we're waiting for them, do we have any of the faculty members in the presenter line?
Hi, Fred. Marika Gray here.
Good day, Dr. Gray. We'd love to hear your reactions from the presentation that we've just provided.
I think this is fabulous. When I spoke initially to CMS about the work that we do here at WellSpan Health, one of the things that limits us is the payment model that we're currently under. Our clinicians are getting more complex patients. Our physicians want more time to think, but they're currently paid on how many patients they actually see every day. And this Transforming Clinical Practice initiative, as well as the changing to the payment program, makes such a huge difference because it allows us to go in the direction that we think medicine needs to go in the 21st century.
Thank you very much, Dr. Gray. Any reactions, Dennis or Paul, that you'd like to share?
Just thank you. Thank you for your past work. Thank you for joining with us on this, and thank you for your comments. If we're all in this together, there's nothing I've been more sure of is that we'll achieve our goals, so thank you.
All right, let me just check in to see if we have any other faculty members on the line that would like to share.
Hi, this is Dr. Kirsten Meisinger.
Good day, ma'am.
How are you?
Excellent, thank you. Your comment, please?
So I would love to share with the group that I have the benefit of being one of the regional cluster coaches as well as the national co-chair, and I have heard tremendous energy on the part of the PTNs and SANs in doing this work. And I think that that comes from the wonderful change package that we've assembled. What we've done is we've really put the patient at the center of the change with this. And I think we're trying to keep that fidelity all the way through, which is allowed and, in fact, enabled by the wonderful work of the MIPS and the other payment initiatives to be able to move things in alignment. This is exactly, I think, what providers and other folks in the healthcare arena have been asking for, as Dr. Gray said so eloquently. I'd also like to say, when you do this transformation, it seems a bit daunting at the first, but then when you really start to get into the changes and assemble a team, the joy with which you are able to approach your patient care comes back so quickly, and you're really able to focus again on why you went into medicine, paying attention to the patients and feeling like you have a wonderful experience every day at work.
Thank you so much, and we really appreciate it. I know Dennis has something he wanted to share.
Well, I'm just so glad that our faculty member used that word joy. And I want to observe, she said there's a lot of energy with the PTNs and the SANs and that it comes from the change package. And I think that's true. I think it also comes from the faculty, and particularly from what we see over and over again in the faculty members, like the two individuals we just heard from, which is, number one, phenomenal results for the patients that they serve, and along with those results, this increased joy, that when you do this work the right way and you're focused on the right things, it makes all the difference in terms of the practice of the profession of medicine. And I think that's one of the greatest gifts that TCPI intends to make available as part of its work, the gift of returning the joy to practice. And we know it's possible because of the experience and the lived experience and the data and the results of the faculty who are part of this initiative.
Thank you so much, Dennis. If we could go to the operator and see if we have anyone in the queue. Do we have anyone that would like to share a comment or make a request?
We do. First one up is Jane.
And if you wouldn't mind
Jane
giving
Anderson,
your full name and your organization, we would greatly appreciate it.
Sure. I'm Jane Anderson. I'm a nurse practitioner at the University of Minnesota. I am the director of our nurse practitioner clinic. And I just want to say how much we appreciate the inclusion of advanced practice providers in this work at the onset. So that's really appreciated from my end. Also supporting the scope of practice and the collaboration that we are able to do with our provider partners.
Well, thank you so much, Jane. This is Paul McGann. We really appreciate you saying that. And I want to give credit to our director, Jean Moody Williams, who is a registered nurse, whose leadership really has allowed this to happen. It's often hard to make that happen operationally at CMS, and Jean Moody Williams really led the way for that. So thank you for your comment.
Thank you so much, ma'am. May we have our next speaker, please? Our next caller that would like to make a comment?
Yes, our next caller is Sabiha.
Yeah, hi, can you hear me?
Yes, ma'am. If you wouldn't mind giving your name and your organization.
Sure. I'm Dr. Sabiha Rauf. I'm from Jamaica and Flushing Hospital. I'm also one of the facilitators for TCPI. I just have a comment to say that it's, first of all, for my personal growth, it has been a tremendous experience to just interact with the CMS leadership, with all the other team leaders, and learn about this transformation clinical practice initiative. And it has been such a tremendous experience, and I think the PTNs, the SANs are doing such a great job. This is not just coming as a mandate from CMS, you have to do it. You are providing tools to the clinicians to help them transform into this new MIPS world and the macro world. So I think it is a great way to transform the entire healthcare system. I am speaking as a patient and as a physician. This is greatly much needed in our healthcare system today. And I believe in this program so much that all 600 physicians from my 2 hospitals have now are in the process of enrolling for TCPI.
Thank you so much, Dr. Rauf. Will we have any comments or reactions for her, possibly Dr. Fleming or Dennis?
Just again, gratitude for participation, gratitude for helping us with this. We're not going to get it perfectly in the early years, but with the approach and the attitude that we've just heard, I'm confident that we can make this a really, really powerful program. Thank you.
Thank you so much. We can go to our next responder that may be on the line.
Yeah, I apologize. This is Jane Anderson, nurse practitioner again. I'm also on the TCPI faculty, and so I appreciate CMS and the TCPI people for including us as well at that level. Thank you.
Thank you so much, Jane. Other faculty members or participants via the YouTube or on the Confertel platform that would like to share?
Fred, I have a request of the audience. I really believe in strategic planning and looking into the future. So I want to try, there's so much information here, it's hard to focus, but I want to try and request either faculty or audience to someone just to take a stab at the 5-year strategic question. Where do you all want your practice to be 5 years from today? Could someone take a stab at that?
Thank you very much, Dr. McGann. So if you're on the line and would like to put yourself in the queue to respond to one of our questions to run on, we would greatly appreciate it. We're also looking for other questions that individuals may have that are participating with us this afternoon. We have approximately 5 minutes before we'll hear from Dr. Conway, and we're going to introduce him in the next 2 to 3 minutes. So any last comments and reactions to what you've heard from Dr. McGann, heard from JP, Dennis?
Yeah, this is
We do have Angela on the line.
Your name and organization, please, sir.
Yeah, this is Sam Seikert from the CCNC PTN in North Carolina. I'm a clinician involved, and we've had a lot of experience extracting quality measures from certified EHRs, and we know that with certain vendors, there's a real difficulty getting accurate measures. And so what do we say to the clinicians who, are at risk in the MIPS program for getting pay cuts when they say, I'm not really sure that these measures reflect my care?
Thank you so much for your question. I see that Dr. Fleming and JP have a response. Dr. Fleming, JP first.
Okay, this is JP. And so I think that your feelings and thoughts about that have been heard throughout CMS very clearly, and you are not alone, and we know you're not alone in that. So I think you will see represented now and in the final rule and in the continuous development of the MIPS program, an understanding and a desire to continue working to bridge that gap and improve the capabilities of EHR in practice.
I'll add to that as well. I've been kind of silent the whole time, but I'm waiting for this question. Thank you. So a primary driver of this entire TCPI model, and of course, this isn't QPP. This is alignment to QPP. But TCPI, primary driver of this, is the person and the patient. Person and family engagement is key to defining quality and defining it from the person's perspective. This is the way forward, and the alignment, the system will align to those drivers. I'm going to leave it at that unless you wanted to say some more things.
Thank you both for your responses. I'd like to check in and see if we have another comment on the line.
This is Dr. Kirsten Meisinger again. I'd be happy to make one more comment.
Thank you very much, Dr. Meisinger, and I think we may have you as our last comment before we introduce Dr. Conway.
So one of my dreams for my patients and myself 5 years from now is that we have a robust enough system that I can stop having different pieces of patients in different small categories, which is, I know, one of the primary difficulties with having multiple payment programs and multiple different categories of risk. I would love to have a much more aligned, perhaps a real dream would be to have a single way to look at the risk and the profiles of my patients and not have it be so divided and have to flip between different metrics for different categories of patients and program. And I think this is a tremendous step in that direction, and I remain enthusiastic even with all of the difficulty ahead, and I actually look forward to the next 5 years.
Thank you so much for that comment. That hit the ball out of the park for my question number 2. And let me just say in response and offer, I pledge, and our team pledges, to do everything we can, because we'll be with you for the next 4 years, to actually make your dream a reality by 4 years from now. I don't know how, I don't have the answer. It's not going to be magic, and it's probably not going to be easy, but I believe that the way to create a new future is to envision it now and then work together as a team to attain that vision. And I think TCPI has given us the resources and the community of practice to enable that to actually become true. So thank you for sharing your dream with us. So hang on, people. It's a little bit of dead air time, but that was very profound, so you could just think about that and come up with a couple dreams of your own. Fred?
Excellent. Thank you very much, JP, for your presentation today, for being able to be here to respond to our community of practice. We look forward to integrating you into further communications that we may have across the TCPI program. Thank you also to Dennis and to Dr. McGann and to Dr. Fleming. We are going to take just 30 seconds or so until we can introduce Dr. Conway. Dr. Fleming's going to do that introduction. We'll hear from Dr. Conway. Then we'll hear from our patient representative. Let me just check to see if our patient's voice is on the line at this time.
Hello.
Good afternoon, ma'am. How are you doing today?
Doing well, thank you.
That's great. We really thank you very much for being with us. As you know, person and family engagement is an important compass component of the TCPI change package. And as we wait for Dr. Conway, we'd love to just hear, if you wouldn't mind sharing a little bit about your story and maybe a few thoughts that you might have relative to the quality payment program that you just heard about, and what it means to you and the care that you're receiving from your provider.
Okay, certainly. First, I want to thank you for the invitation to share some of my thoughts today. This initiative, the TCPI, is very important to patients. Patients spend the majority of their time in their homes and in the community. So working with our regular community clinicians to improve care is really important. This new legislation, MACRA, is also important to patients. As a patient that regularly sees my doctor, my health is my priority. Knowing that my doctor, moving forward, will be working to partner with me better to improve my health status, that encourages me. The work of the TCPI, PTNs, and SANs will help to support these improvements as we work toward MACRA. And integrating patients in this process will also be important to this goal. Primary care doctor is a member of the TCPI community. I believe in the process she used to begin transforming her practice because she included me, my husband, and a group of other patients on the practice's Patients and Family Advisory Council. And it helped her and her colleagues to understand the opportunities to improve their work and the practice. Our work contributed to improvements that impacted the back office, front reception process, and even the processes for patient care. And in closing, I strongly support including real patients like myself in that improvement process and preparing for MACRA. Thank you so much.
Ms. Jean Marr, we really appreciate your feedback. We appreciate your thoughtfulness in terms of the relationships of what the quality payment program is doing and how it matters to you and how you've experienced effective engagement around person and family care as a part of your healthcare delivery system and with your provider. We greatly appreciate you speaking. We would love to have you stay with us on the line. Would you happen to have a little while, ma'am?
Sure.
Excellent. I'm going to turn the event over right now to Dr. Robert Fleming, who's going to introduce Dr. Conway. Dr. Fleming?
Thank you very much, Lieutenant Butler. Rounded off for such a great event. It's generally my privilege to introduce to you today someone whom many of us would consider to be one of the greatest CMS leaders of our time. An individual that creates and delivers true impact, and an individual at the center of one of the greatest movements of our time, where healthcare transformation, and I'm going to borrow from the Gettysburg Address for a minute, shamelessly, but healthcare transformation is guided by the person, for the person, and of the person. Dr. Patrick Conway, we are honored to have you at our TCPI event today and honor your steadfast commitment to create better care, smarter spending, and healthier people. And of course, just to give you a brief synopsis of Dr. Conway's resume, it speaks volumes to these commitments as the Deputy Administrator for Innovation and Quality and CMS's Chief Medical Officer. Now, for those of us that are less familiar with government speak, this represents actually 4 separate roles that Dr. Conway is playing at CMS as the Deputy Administrator, the CMO, and also leading the Center for Clinical Standards and Quality and the Center for Medicare and Medicaid Innovation. Dr. Conway, without further ado, again, we thank you again for your leadership and support for our TCPI aims. Sir, the floor is yours. Thanks.
So thanks a lot. Thanks to having me here today, speaking with you, to TCPI team, and to all of you delivering care across the U.S. and on the webinar today. Really appreciate it. I think, I do want to thank you for your commitment to patients, your commitment to quality, and your hard work. We are asking for your partnership. This is an all teach, all learn environment. We will learn from you. You will learn from each other. I think together we can drive major change across the U.S. So I want to thank you for that, and most importantly, better outcomes for patients. and love the session that we just had. Some questions for us to consider together. What needs does your practice have that the TCPI model can help you achieve? How can your practice become involved in TCPI activities to prepare for alternative payment models and MACRA and other payment reform changes, and to prepare and be successful for you and the patients you serve? What actions can your practice take over the next month to better connect with your practice transformation network or your quality improvement organization and or your support and alignment network? How do we get here today? This initiative started actually with me and many others thinking about physicians and clinicians that we had interacted with that had challenges, including many in my own family, smaller private practice physicians and clinicians that had challenges delivering the care that they wanted to deliver to patients each and every day, and we wanted the support to deliver that high quality patient care all of the time, to participate in these various models, to measure and report quality measures, and to improve significantly. So we really think this model demonstrates our commitment of our time, our resources, and our effort to support all of you in the field delivering care across America. So the context for this, we are in a payment shift. I just finished an interview talking about, sorry about that, I'm having controller difficulty, a payment shift across the U.S. So we are moving to alternative payment models. We set a goal to have 30% in alternative payment models by the end of 2016, actually reached that goal about a year ahead of schedule, a goal of 50% by the end of 2018, and 85% of payments tied to quality and cost, and actually reached that goal ahead of schedule as well at the beginning of 2016 as opposed to the end of 2016. And this is the public and private sector working together to reach those goals. So of course, what is TCPI? I'm sure you've heard a lot about this, but we've got 39 national and regional healthcare networks across the country. Our goal is to transform and support care for more than 140,000 clinicians and physicians. I am still a practicing physician. I work on weekends in the hospital setting, so I understand the challenges of working in a busy practice environment. I know many of you have an experience that I no longer do have of working in a busy primary care clinic or specialist clinic where you're trying to deliver high-quality coordinated care to people with many complex, both physical, social, mental, behavioral health needs. So how do we support you in delivering person-centered care as best as possible and really coordinating care for the patients and families that you interact with every day? This is an over $650 million investment over 4 years from the federal government, so one of the largest innovation center investments. Our goals are a deep partnership to drive better care, which I know aligns with your goals, and really return to the joy to the practice of medicine why all of you that do practice medicine, why you went into this field as a physician, a clinician, a nurse, a pharmacist, et cetera, why you dedicated yourself to serving patients. We do believe in setting goals and using data to achieve those goals. I'm not going to read you all these goals, but we think we can achieve cost savings, we can improve health outcomes for millions of people, reduce unnecessary hospitalizations for 5 million patients. These are bold goals, and this isn't about CMS. It's about you in the field, in states, communities, regions, practices, achieving these goals. We will help roll up the data and summarize the results, but this is really about the work that you are delivering each and every day. Understanding clinician needs, we will continue to try to listen and learn from you and understand your needs. We know there's a significant demand on your time and that these payment reform changes are coming rapidly. This issue of serving patients with multiple chronic conditions, most of the patients I take care of now are children with multiple chronic conditions that are hospitalized. So serving their complex medical, social, and other needs, we'll try to support you for those patients that you serve. And our goal is to partner with you, to listen, to collaborate, to help you succeed and deliver high quality care. We are trying to model what we're asking you. We are trying to be a learning organization as well. These are primary and secondary drivers. I won't go through all the secondary drivers, but person and family-centered care design, continuous data-driven quality improvement, and sustainable business operations. You know, if you think about some of our national faculty, just a few of the quotes here I'll read to you. All primary care providers deserve to work in a supportive environment. One doctor can no longer do it all. We need a team. What I did alone years ago, now a team of 7 does. Now it works and it's fun. From Dr. Meisinger, you can see here. Rapid transformation of a small traditional rural practice is possible and fun. It has put us in teams and the physicians love it, accomplishing more in less time. And then just lastly, I won't read the bottom 2, but the next one, for the first time in my practice, I see the light at the end of the tunnel. TCPI is providing the opportunity to assist clinicians to getting back to what they went to school for, taking care of patients. So I think just a tidbit of the quotes from you out in the field doing this work and our faculty. Our request of you, and this is the last slide, so I'll even finish maybe a little early. We're asking for your assistance in creating a new reality for healthcare delivery, and we need your help. We want to listen and learn. We want to learn based on data and information. We'll need to continue to test changes, to test interventions, to teach each other what works best in different care settings. Stay involved. Please actively participate with your practice transformation networks, with the support and alignment networks, our faculty, your quality improvement organization, and with each other. And with that, I want to end where I started. I want to thank you for the work that you do. I know many of you each and every day are doing the best you can to deliver high-quality, patient-centered care to the patients and families in front of you. Our mission and goal is to help you in that effort. As Don Berwick, my first boss at CMS, said to me, Patrick, you're doing great work, just do it faster and better. So we will work with you to support your quality improvement journey and delivering that highest possible quality care to all patients and families. So thanks for having me here today, and I really appreciate it.
Thank you very much, Dr. Conway. We know that you have a very busy schedule, and we thank you for taking the time to be with us and to provide those leadership thoughts and commitments and actions to our team and really kind of build off of what we're hearing is working from the field. Now we are moving into the next component of our discussion, and we're really wanting to check in with the CMS leadership team to hear from them and to also react to a number of the questions that may be coming in or individuals putting themselves in the queue. We'd also like to get their reactions to what they heard today during the sessions that we had, both today and yesterday, kind of giving us a little bit of what their largest insights may be in terms of the actions. We have an opportunity to continue some of the dialogue that we were having relative to the requests and offers from the PTNs and SANs. I'd say we have about 30 minutes. So let me just first check in with the operator to see if we have anyone in the queue that would like to propose a question to the panel.
Thank you, Fred. Up next is Deborah Warner.
Good afternoon, ma'am. If you wouldn't mind giving your name and your organization, please.
I'm sorry, we're going to wait on that.
Operator, do we have
As
someone?
a reminder to queue up, please press 7# on your phone now.
Thank you.
We have Denise.
I apologize. I didn't hear your name. If you wouldn't mind giving me your name and your organization.
Hello?
Yes, ma'am. We can hear you. Would you mind sharing your name?
Oh, great. Hi. Yes. My name is Dr. Denise Daub. I am a solo practitioner in New Jersey, so I am supported by New Jersey Innovation, New Jersey High Tech, I heard a lot of lofty goals. I have been in practice for more than 20 years, and I'm trying to take care of my patients in the very best way and refer them to the very best people. Sometimes some of the goals, we're not quite sure what they are because they haven't been quite defined yet. When I control my diabetics with hemoglobin A1Cs of 7, and the information needs to come into my certified integrated EMR by the labs, and I have to worry about LOINC codes, and is the information coming in right, and is this system capturing all of my work? The reality is right now, no. And so then we have to call up high tech and find a way to capture it. Or how do you know that for all my lower back pains, I'm not getting x-rays or I am getting x-rays? How do you measure me? How do I know my QR/UR shows that I am putting out a good effort? I don't see the measurement. And when I go on the Medicare site, if I can't get on myself to see the QR/UR, hours of my week are spent with a Medicare helper, not in the PTN, who says, gee, you seem excited because you can't view your... I want to view what I'm doing. I want to view the work. I want to view the fact that I'm doing the pulse forums and that we're engaging the people into speaking about the metabolic syndrome, the diabetes, the hypertension, and the hyperlipidemia, and getting the forums from Mass General, who may think that people in New Jersey don't engage their patients. And I know that I'm a relic. I am a solo practitioner who follows patients into the hospital, out of the hospital, and has 4 or 5 people at 104 years old that I house call. And I call those patients the day after, even though I'm supposed to have a special person who does that. Somehow the lofty goals are wonderful, but it's creating more work, and sometimes the patients wonder, is this necessary? When I ask them 3 words in 3 minutes, or the common objects in the room during their Medicare wellness visit that they think is a real exam. So they come in wanting to be examined. Maybe I'll find a lung cancer, but I'm not supposed to touch them. I'm supposed to ask them questions. So this is a very complex system. I practice full-time. You can hear that. I love my patients. I hope you can understand that. But hopefully you can also hear my frustration and my lack of understanding. And how do we go forward? My goals in 5 years, when you ask me, I'm 58 years old, I wonder if I'll still be practicing, or will I give it up and join a multi-specialty group where I guarantee you no one in that group knows my patients like I do. I'm done. So what would you all say to that, to the primary yo-yo in New Jersey?
Well, thank you very much. I'm sorry I missed your last name, but Dr. Denise, I'll call you. I got that much. And,
thank you.
And we did hear you. We heard you clearly. I heard I'm a physician myself. I've been at CMS for 15 years. And I hear your dedication. I do hear your caring. I hear your passion, and I also did hear your frustration. And I know exactly what it is you're talking about. We're at the very beginning now. We're still in the first year of a 4-year commitment from CMS to try to make a very big impact on all of the things that you're experiencing, Dr. Denise.
Right.
As Dr. Conway just said, there's actually a $680 million investment in this program over the next 4 years. And our intention, we're not perfect, and as I say, we haven't got everything down straight yet, and so it clearly hasn't trickled down to you, but we have huge investments in New Jersey, I know in particular, and New York.
There are some wonderful people in New Jersey and Newark, and I love them, and they wanted me to participate today because they know I'm rather bluntly spoken. But remember, the buck stops with me, sir. So when the guy gets admitted into the hospital and they don't see his white count and he's Medicare and they have 104 fever and he's in the ICU and his white count is 100, who do you think gets him transferred to the tertiary care center? I'll let you guess.
Yeah, it's you, I know. I've been there.
Yeah.
I've been
And
there
then
myself.
I have to worry if the LDLs aren't coming into my electronic record showing that I'm controlling. And Ron Menke and all the great people in New Jersey say, Dab, we know you do some work. How come how come we don't see it when we review your record?
So that's my point, Dr. Neese. My point is that the funding for this project, which includes the data processing, is going to the Practice Transformation Network in your state of New Jersey. And our hope is, we are at the beginning, we're still in year one, our hope is that with this funding, which is considerable, that the challenges of the data capture that you've described will be solved. And I know we're working with the project officer for New Jersey right now about their program of work, and we're hoping that by this time next year, we can talk to you again and you will be able to report substantial progress on the things that matter most to you and your patients.
I hope so, and I would love to speak to you. If you still feel the same way, I'm extraordinarily optimistic.
Great. Thank you very much for calling in.
Thank you so much,
sir.
ma'am. Thank you, Dr. Neese, for your comments and your passion. We'd love to hear from the next person that's in the queue. Operator, if you wouldn't mind sharing.
Currently, no one else on queue. Again, as a reminder, please press 7#.
Fred, this is Marika Gray at WellSpan Health.
Good day, Dr. Gray.
I just wanted to comment, and I had to jump in because since we started with the Gettysburg Address and I was in Gettysburg today, I felt compelled to comment on Dr. Conway's presentation. And I think the most powerful thing about this is actually what Dr. Denise also found a little frustrating in the fact that this is that all teach, all learn environment that Dr. Conway talked about. And when we're doing this to really get to the dollars and the payments, we really want a structure that we can follow. But I think as well, CMS recognizes that they don't have all the answers at this point in time. They're going to put together the best package that they can, but this probably will morph and change according to our feedback. And having been in programs in the years past where I've been frustrated because they never change and they don't reflect the reality of everyday care, to know that change is actually built into this program is really refreshing for me.
Thank you very much, Dr. Gray, and thank you for your leadership in bringing that real-world expertise and care and improvement success, not only to the faculty, but also to the PTNs and the clinician practices that they're supporting. I'd like to turn to one of our CMS leaders that's on the line. Let me just check in and see if Ms. Debbie Hattery is on the line with us.
Yes, good afternoon, Fred. I'm here.
Good afternoon, Ms. Hattery. I know that you had a few reactions to the content over the last 2 days and things that you may have heard and kind of some key messages that you may want to share, ma'am.
Yes, thank you. So first of all, I'd like to thank everyone who's been involved over the last 2 days and particularly with the engagement, the conversation, the feedback, the ideas that have been generated here. So those kinds of things can only help us do what we need to do better. The idea and messages about change are important, and hopefully if you've gotten no other point out of this, that we are here to try to help and to be available. I think one of the powerful messages that we want to make sure gets communicated have to do with the sort of three sources of AIMs within TCPI and what TCPI is available to provide, and that is that the PTNs have AIM commitments, practice-based AIMs, and patients co-deciding on AIMs. I know I heard from patients and a patient this afternoon. We value the PTN's reaffirmation of your award commitments and the strategies that you have established to accomplish those aims, that you will work collaboratively with the practices that have already established their own practice-based aims and align your work with them using the change package, TCPI faculty and other TCPI resources. There is a reason that we have invested the $650 million that was referenced earlier in this, and that we want to use that to help everyone be successful here in transforming enrolled practices to achieve the outcomes and goals that we know will produce significant spending reductions. So I think that's probably the key message that I would have, and would turn it back to you, Fred.
Well, thank you very much, Ms. Hattery. Ms. Hattery serves as one of the senior leaders in the Center for Clinical Standards and Quality, working with Jean Moody-Williams, Dr. Kate Goodrich, and Dr. Sherry Ling. And we thank you so much for your time and commitment this afternoon to share your reactions and reflections on the content that you've heard and your support of the Transforming Clinical Practice Initiative. I'd like to turn to Dr. Robert Fleming in just a second, as he wouldn't mind preparing himself to give any remarks to our community relative to the overall model and any of the insights that he may have had over the last 2 days. And I also wanted to just put Dr. McGann and Mr. Dennis Wagner on cue to follow Rob if they wouldn't mind. So Rob, if you'd like to join us here on the podium, that'd be great.
Great, thanks. Yeah, I appreciate that again. I certainly don't want to be the last to speak here, but first of all, thank you for your attendance. This is a very important event. We certainly have plenty of events with the TCPI model, and I want to actually emphasize that there's a few points here. During the very first part of a 4-year model, 9, almost 10 months in, we've made great progress. And I want to emphasize and highlight where that progress lies. That progress lies in the development of a community of practice that emphasizes the person-family engagement goals, that emphasizes joy in practicing, that emphasizes sustainable business operations. This is really important to emphasize here. I think that as a person that has run a few models in the past, this model in particular has been so aggressive in meeting goals and setting very bold aims to create new systems that generate real results. I'm very, very confident that we're going to get there. I hear on both sides of the spectrum joy and optimism on one side, and also frustration and practical application and how we're going to execute this on the other side. Along the way, we're there with you. This is a really very important, rare, I believe a rare occasion that we can actually make a difference, where we can put the person back in control of his or her destiny. I'm going to leave it at that, turn it back over to anyone else that would like to make a few more comments.
Thanks, Rob. This is Paul McGann, and again, I just want to say how delighted we are to be with you this afternoon. This opportunity we've had this afternoon, I don't know how many of you have participated with CMS learning sessions about payment rules, but this was one of the most gratifying experiences of my entire time here. There's something about reaching out to you directly, to having clinicians on the line, and to being allowed to have dialogue about very important payment rules that influence hundreds of thousands, more than 1 million providers and millions of patients around the United States. It's not perfect, and we heard examples of frustration, and we know that frustration is out there, and it's good that we're able to come together and talk about it. I believe, and I think my colleagues here believe as well, that we're on the first beginning of a pathway to address the frustration that's out there. And I want to end by drawing a distinction between an educational model or an educational session about a payment rule and what we're doing here as a large-scale collaborative quality improvement project. And the difference can be said in one word, and that word is action. What we want in this project for the next 4 years is for all of us, and that includes every one of us in the room at CMS, and every one of the clinicians, and all of the participants in PTNs and SANs and support contracts. We want everyone here, and everyone who can hear this message, to be focused on action. And some of you might be so frustrated that you say, what do you mean action? I have action every day. What action are you talking about? And so I have an answer to that question for you. The action all of us should focus on is the action that will enable us to achieve the goals we've set. Dr. Conway outlined what was called the lofty goals for TCPI, and those are good, but I agree with the questioner, they are lofty. But I want every clinician listening to know that the practice transformation networks that were funded by CMS with the $680 million received their grant by listing specific goals and aims that they committed to achieve in partnership with you and with us over the next 4 years. And so the answer to the question about what action is it that makes it different from an educational model is the action to achieve the goals that were enunciated in your practice transformation network. So for all the clinicians out there that are wondering what this is about and how to translate lofty goals into actions, meet with your PTN. Ask them what the goals are that enabled them to be funded. Ask the PTN for their proposed solution to the measurement questions, to the EHRs, to the vendors. Each PTN was funded because in our judgment in competition, they gave creative and intelligent answers to all of those questions. So reach out to your PTN, participate in the community of practice, and together I am very certain that we will reach our goals 4 years from today. Dennis?
Yeah. Thank you, Dr. McGann. And I do want to say, particularly to the clinicians who are on the line here, thank you for your hard work and for your caring of the patients that together we serve. I will say that I think the past couple of days and this session reflect this as well, that CMS has invested in the A-team here. You heard directly this afternoon from our Deputy Administrator and Chief Medical Officer and the Head of the Innovation Center and all the other accountabilities that Dr. Conway has, is deeply invested in this work, cares a lot about it, and works with us every single day on what we're doing here. Dr. Robert Fleming and his team are deeply committed to this work. They bring energy, they bring esprit de corps, they bring talent, they bring commitment to this. The investment that we've made in practice transformation networks, I think we have just the finest possible set of 29 practice transformation networks and 10 extraordinary support and alignment networks. The American Medical Association, the American Board of Family Medicine. You know, we were on our working session with these colleagues all afternoon. Dr. Bob Phillips called in for ABFM from Auckland, New Zealand, with a whole series of requests and offers to keep the momentum and the action moving. So we definitely have the CMS A-team, the PTN A-team, the SAN A-team, the QIO A-team. There's a major investment here by a lot of people who care deeply. And I'm confident that as a community of practice, we are going to achieve the results that we are setting out to achieve. And I believe that 4 years from now, when we look back at this, those clinicians who are involved in this work, those extraordinary TCPI faculty that are showing us the way how to do this work and showing us that we can succeed in it and experience joy in our success, the PTNs, the SANs, the QIOs, my belief is that we're going to look back on this 4 years from now and we're going to say this was the best and most rewarding experience of my professional career. That's what I believe. I think we're on that pathway already. I know I experience joy and privilege every single day in the work that we get to do together, and I'm just delighted to be part of this team and I'm delighted to be part of this transformation movement. I think it's exactly the right work at the right time, and we've got the right people performing it, and I'm happy to be part of it. So, Lieutenant Butler, I think we may be reaching a close here. Is that right?
Yes, sir. We are ready to come to a close for this afternoon session. We did want to take an opportunity just to check in and see if we have any other clinicians and or healthcare delivery system individuals in operations or any other component of the system that wanted to share or provide any reactions before we close today. Let me just check in with our operator to see if we have anyone that has themselves in the queue.
We do. We have a couple. The first one up is Dr. Shaw.
Good afternoon. If you wouldn't mind providing your full name and your organization.
Hi, this is Mobina Shah. I'm a family physician from New Jersey. I'm very new on the boat and thankful to NG High Tech to get me on board with this. I've been listening and I've been a part for Meaningful Youth for a few years, and I think this is a great program, and I'm very honored and delighted to be a part of this. I do agree with Dr. Conrad's frustration, which we as providers in solo practice are facing. And I think a very important point that nobody is addressing, and I think is that the most of the frustration is coming from the point that we're all pushed for time and working hard to try to make the ends meet. So much so that my partner, who works with me, who's my husband as well, had to leave the practice and get another job while we go through this transformation. Transforming clinical practice is what the way the future is, and I'm very excited, and we will all work towards it. And I think you guys have these great ideas, and of course not a final plan, but that's why we're together to discuss and to come up. I did recently put in CCM into my practice, routine annual wellness visits, and I'm seeing the results already, but it all takes time. It's not possible for one provider, and the expectation is that we hire more people, we recruit more people. I'm basically banking a lot on volunteers, like students, and I do a lot of training for a lot of interns, for nurse practitioners and physician assistants, and they help me with a lot of projects. But how long can I do it this way? So I think a part of this project that's really going to help is to look into how physicians can get paid while doing this, not get paid at the end of showing the results, but get paid there a little bit so they have time and energy. And I think, and I could totally relate to when she was speaking. And, I personally am facing this. I have 2 offices. For now, I'm running them on my own because my partner had to go out and do something else so he could support the practice. And I just wanted to bring this point up. I think because we're all starting up, and I don't know how this translates into the technicality of this issue, which all you understand as our leaders. And other than that, I think it's a great project. I think we can achieve it if we work together and take, like you said, action. Like I'm big at talking to families and coordinating with them, but that all takes time. And then when I document it in my notes, it's just not enough. So that's the second point. How do we prove it that that's what we did? And of course, I leave that up to you guys to create a plan how we prove that. Thanks.
Thank you so much, ma'am. We want to go to Dr. McGann and Dr. Fleming for their response.
Thanks, Fred. And thank you, Dr. Shaw. That was very, very elegantly spoken. I think the main responses I'd have to what you shared is that the reason we brought together such a large project is so that we could create a national learning community. And I hear where you are as you describe your practice in New Jersey. And what I can share with you from the preparatory work we did for TCPI is that we have a quite remarkable national faculty assembled. You've heard from some of them in the program today. And this faculty has come a long way on a journey that started from exactly the place that you're in today. And these faculty are a national resource. They're a national treasure. And I would encourage you, as you said with the program, that it's a big program and you're honored to be with it, to stick with it, and to stick with it in the sense of a learning community, and to listen and learn from the faculty and others who have faced the challenges you're against and have managed to overcome them even before the payment changes that are coming along. And the second thing I wanted to let you know, because you might not have heard about it, and Fred, we're going to be putting together educational programs about this as well, is that CMS just released the next physician fee schedule, proposed rule last week. And that physician fee schedule has 6 new care coordination codes in it, which will allow you, when it's finalized, and that means starting next year, will allow you to bill for a lot of the activities you do now that you don't get paid for to coordinate care. And we're going to have more educational sessions so that you can learn more about that in the future. The Quality Payment Program, QPP, that you just heard JP talk about, contains numerous mechanisms that will directly address the issues of payment and reimbursement and time management that you're concerned about. These are big programs. They're national payment systems. They've been embedded for 40 years, and they don't change quickly in 1 month or even 2 months. But because of the program you're in, TCPI, you will have connection to the evolution of delivery system reform payment systems. And I'm confident, as my colleagues Fred and Dennis Wagner and Dr. Fleming and all of the program is, that over the next year or two, you will see tangible benefits from learning about how delivery system reform is going to come to you at the front line in your work with your patients in New Jersey and all over the country.
I'll add to that. Obviously, there's a lot that's been said already, but the most simplest and clearest way that I look at this is, as I've heard before, said by leadership. Aims create systems, systems create results. And what you're hearing from Dr. McGann right here is at that systems level. What's happening is a transformation, a fundamental transformation of systems, from a government payment system transformation to the practice transformation system, to also, I would go so far as to say, the person is being transformed in this system as well, taking accountability over his or her own health care and getting rewarded to do so. At the center of it, everyone has an incentive to take care of themselves. But these systems are fundamentally unprecedented, in an unprecedented way. They are changing before our eyes. I'll leave you at that.
Thank you very much, Dr. McGann. Thank you, Dr. Fleming. Let me just check in with our operator to see if we have others on the line that would like to share a comment, or anyone in the room that would like to come to the microphone and share anything.
We do. We have Deborah Warner with Total Cardiology Care.
Thank you so much. Good afternoon, ma'am.
Good afternoon. My name is Dr. Mary Abbott, and I am a private practitioner in a cardiology practice of 6. I also wear a different hat in an administrative role at a teaching institution in the state as well. I appreciate all your slides and the discussion of what MIPS is about, because that certainly will be where we start. My concern, along with Dr. Denise Daub, who I happen to know and haven't talked to her in about 15 years, hi Denise, and Dr. Shaw, is I am very concerned about the implementation process. And I think we hear about the $50 million that CMS has set aside for the networking process in New Jersey and the 680. In attempting to, or starting to do this, what comes very quickly to the table is the need to have people do this integration of having the ability to gather the data. That's a tremendous cost to the private practice. I don't think anybody's looking at that. I think Denise's point that the data has to be accurate, because you're tying reimbursement to the private practitioner to that data acquisition. If the data acquisition is not accurate, your payment to the physician will not be accurate. The physician I feel I have to hire 2 people to help me with my quality metrics, to help me with the advancing care, to be able to achieve these points. I don't know where CMS is looking, or is anybody looking at what cost that's putting on the private practice until we become part of the bigger organization, where I think the goal of this is that we become one system. You know, as a leadership in the hospital, I see where we have our metrics that when we don't meet them, what we have to do to make length of stay go down, what we have to do to make sure our heart failure program meets core measures. It's a lot of resource, and I'm not sure that this whole project is looking at individual practices and what cost that brings to the table. I'm concerned about the implementation process. I don't see that being a very smooth process, or that we're really and I know it's the beginning and it will require time, and the pendulum will move one way and perhaps change as we find that something doesn't work well, but I think that there are some major financial cost to the practitioner that is not being addressed at all by this change in the system.
Thank you very much for that. Those are all very intelligent comments. Could I ask you a question? Have you discussed the potential solutions for the conditions under which you're working with your own practice transformation network?
Well, we've started the process, so they've been in our office. They are in the process of looking at our systems. But when we look at the quality metrics we want to pick, because other questions, do we apply individually? I have 2 internal medicine guys in my practice. Can we separate them if the tax ID number is the same? If we apply individually, does each of us have to use different metrics, or can we use the same metrics? But I think the data acquisition, just to hit those numbers, is going to be resource intensive and have dedicated people doing that.
Great. Well, this has been very useful, and we have a proposal here on the basis of which your Practice Transformation Network was funded. So we've been taking notes about all of these comments, and we're going to go back to the proposal, and we will conduct a meeting with the Practice Transformation Network in your area and explore this further as partners to achieve solutions to the issues that are frustrating you the most.
And I apologize, Dr. McGann, did you capture the PTN that she articulated?
I've heard 2 from New Jersey, and I believe the last one was from New Jersey as well.
Okay, ma'am, would you mind just clarifying which PTN you've been partnering with? Our last caller.
Garden State.
Garden State.
Garden State, thank you so much, ma'am. We just want to make sure we're having the right conversations with the right organization. Operator, do we happen to have anyone else in the queue?
We do. Next one up is Dr. Daub.
Yes, this is Dr. Daub again. Are you hearing me?
Yes, ma'am, we are.
I spoke before. I know Mary Abbott, the cardiologist that just spoke. She is not far from me. We are all part of PTN New Jersey Innovation Institute in New Jersey, in the Northeast area. That was your question.
Yes, ma'am.
I agree with her. I am a primary practitioner. Mary is much more eloquent, and she does also serve to help the hospital meet their goals. She has wonderful ideas, but we're talking about the practicality of meeting goals, and we all have different charts, all different systems. Athena, amazing charts, not like the VA that has one chart. And getting the information into the chart so we can show you how we are excited about going forward and about meeting the goals, the lofty goals. But when you run the reports and the numbers aren't there, it is frustrating. And we're all taking more time to push it forward. We admire you at the top, so we're pushing also. So I just want to clarify that we do have a good team of experts in New Jersey helping us. However, there are some real problems, and we do appreciate that you're addressing them. Thank you.
Thank you very much, Dr. Daub, and we greatly appreciate your support of your fellow colleagues and that peer-to-peer sharing and learning that we have across the TCPI network. We are drawing to the top of the hour, and I'd like to just check in to see if we have any other individuals in the queue that possibly might be in a different part of the country, maybe serving a different population of focus, possibly a much larger network of clinicians that would like to share and give any reaction and or provide any questions or comments to the CMS leadership team.
We currently have no one on queue.
All right, let me just take a second for anyone that is in a different part of the United States or in a different type of system to put themselves in the queue by pressing 7#. We recognize that there's quite a bit of diversity in terms of the types of practices, the types of practitioners, size of practices, and the patient populations that they're serving. Last call for anyone on the line that would like to articulate any thoughts or ask questions from the field. Okay, I'm going to turn to our colleagues here on the panel to provide us any last closing remarks that they would like to share as we approach the top of the hour.
Thanks, Fred. So this is Paul, and I'll just say, you know, continuous quality improvement is a wonderful thing. And as Don Berwick used to say, every defect is a treasure in quality improvement. And so as we start this program in year one, we understand that we're starting from a system that has not been optimized, but I've been doing this and trying to optimize here for 15 years, and I can tell you there's never been a more exciting time than now. The laws are changing. The reimbursement systems are changing. You heard the QPP program explained. You heard Dr. Conway talk about alternative payment models and advanced alternative payment models. I just referred to the physician fee schedule that came out last week that has brand new codes for care coordination in it, including care coordination for persons with cognitive impairment that's in my field of internal medicine and geriatrics. This is a very, very exciting time. And for people who have AIMS, and all practice transformation networks have AIMS or they wouldn't have been funded, and for people who embrace the local AIMS and the local systems, however imperfect they may be, and who are committed to change over the next 4 years, you heard many different ways today about how participating in TCPI will be a great advantage to you as the delivery system reform unfolds over the next 3 to 5 years. So I encourage you to stick with it. I encourage you to be optimistic, and I encourage you to study the aims that came with your Practice Transformation Network funding, because it's those aims, as Dr. Fleming said, that will create the new systems of the future that will enable us to achieve the goals we're after. And the best news of all is that you have a carefully selected faculty, all of whom have actually experienced and accomplished what we're asking for. Every member of the faculty has demonstrated results on aims just like the aims that we're all trying to accomplish in TCPI. So this isn't theory. You are surrounded by a community of practice and a learning community, and you have access to faculty who have actually done it and are in practice and doing it more with us over the next 4 years. So this isn't something that's dreamed. This is something that actually we have lived experience, and in TCPI and our learning community, we are going to be successful over the next 4 years.
Yep. This has been a great day. It's been a great couple of hours here. I am delighted to be part of it, and I will just say, as one of the CMS members of the CMS leadership team, that you do have our commitment that we'll listen, that we will team, that we will do everything in our power to support the clinicians, the PTNs, the SANs, and others that are part of this work. And we won't always have the answers, but I think what we have learned is that if you get a big enough community of practice working together, that there are answers. And it's a matter of asking the right questions and then listening when those answers surface from people like the faculty, Dr. McGann, that you were just addressing, that with all the constraints and all the barriers in the current system have been able to generate extraordinary results to overcome some of those frustrations, not all of them, and to experience joy. So you have our commitment to listen, to team, to collaborate, and to do everything we can to make the answers surface throughout our community of practice. Dr. Fleming?
I'll end with this. The three-pronged approach is the intervention to this model test. It's how do federal and state initiatives, resources, policies, practice transformation networks, support and alignment networks, how do they intervene to create better patient outcomes and, of course, a reduced cost of care? Value to the person, value to the American taxpayer, and of course, I think profound transformation in the healthcare of the future in this United States. I'm excited. I get goosebumps just thinking about it. Certainly a lot of work to be done. We're in the beginning of a very profound model, and I believe in it as well. I appreciate, of course, the leadership, all that presented today. What a great forum. Thank you.
Thank you very much, Dr. Fleming, Ms. Debbie Hattery, Dr. McGann, Mr. Dennis Wagner, and last but not least, most important, we thank our patient, Ms. Jean Marr, for sharing her support, for being in action with her provider, and for the patients that are engaged and involved with each and every event that we produce for the Transforming Clinical Practice Initiative. Without you and your responsiveness, I think we would be further behind, and because of you, we're addressing items in a different way. So thank you very much, and thank you to the colleagues and those that have joined us in the auditorium today. This concludes our event, and have a safe and restful evening. Thank you.